Namaste and good afternoon to everyone joining today. I am Shalaka Parab from Mumbai. I'm a co-founder at Pulmonary Hypertension India, and I happen to live with pulmonary hypertension myself. Pulmonary Hypertension India, or PHI as we call it, is an organization set up for a very specific, invisible, chronic and debilitating illness called pulmonary hypertension. The uniqueness of this group of our organization is that it is managed by the patients themselves with a common goal of empowering, educating, and enabling Indian PH patients to make good decisions and the right choices in dealing with this life-changing condition. We do this by making knowledge, access, and community our primary goals. World PH Day, which was on 5th of May, just passed us by, and we celebrate the whole month to mark PH awareness. And we try to bring educational material across India to reach out to as many PH patients as we can. This is us, India's one strong patient voice in the fight against pulmonary hypertension. Today, we have a very young cardiologist and a super specialist who works in this space, Dr. Talha Meeran. He heads the heart failure clinic in the Department of Advanced Cardiac Sciences and Heart Transplant at Sir H.N. Reliance Foundation Hospital and Research Center in Mumbai. Dr. Talha completed his MBBS from BYL Nair Hospital, Mumbai. He then completed his MD Internal Medicine at the reputed Johns Hopkins University. Thereafter, he pursued 2 fellowships in the US. One was in general cardiovascular medicine at Allegheny General Hospital at Pittsburgh, Pennsylvania. He followed it with another fellowship in advanced heart failure, transplant cardiology, pulmonary hypertension, and mechanical circulatory support at the same hospital. Dr. Talha happens to be the only USA board certified cardiologist in India with advanced certification in managing critical heart conditions. He specializes in the diagnosis and treatment of heart and vascular diseases such as advanced heart failure, pulmonary hypertension, and rare forms of cardiomyopathy. He is currently active in the transplant space in India as well. He's an executive committee member of the Society for Heart Failure and Transplant in India. He also serves as a co-chair of the Heart Lung Transplant Subcommittee of the Zonal Transplant Coordination Committee in Mumbai. He has co-authored 8 research papers and 11 conference publications. Dr. Talha happens to be one of the few pulmonary hypertension and heart failure experts in India, and it is therefore a privilege and an honor to have him here today. Welcome, Dr. Talha Meeran.
Thank you, Shalaka, for having me here, and thank you all the patients for joining in. Before we start, I think I must put in a strong word for PHI. PHI has been doing excellent work. I was introduced to PHI probably about 4 or 5 years ago, and I've seen it grow leaps and bounds. It's not only about forming an organization, it's about creating a platform to deliver the right kind of message and to empower and to help the PH patients. And I've seen you guys go, really take the efforts to go right to the roots and, connect directly with the patients, be it wherever they are, whichever part of India, and try to connect them to all the, few PH expert centers in the country. So thank you, PHI, for doing what you guys do. And
thank you so much.
As an extension of that, celebrating World PH Day, I think this is the perfect opportunity to talk more and discuss more about pulmonary hypertension.
Thank you, Dr. Talha. So we have 3 topics to discuss today: how to read through the echoes, observing signs of heart failure, and management of persistent cough. And we are going to start with a 2D echo session. It happens to be a subject about which 99% of us are illiterate, in spite of it being the most common and the most frequent test that we all undergo. And I would like to mention here that Dr. Talha happens to be, you happen to be conferred the highest level of certification, that is level 3, for performing and interpreting echocardiograms by the American Society of Echocardiography. And therefore, Dr. Talha, you are our top choice for this session. So over to you.
All right, great. So, let me start off by saying you don't need to be an expert. You don't need to be an echo expert in, performing an echo in pulmonary hypertension and interpreting it correctly. I believe most of our listeners now, I would say about 90% are themselves pulmonary hypertension patients or survivors, and may not have all the medical know-how of understanding each and every technical term on the echo reports. But, the idea of this session is just to make sure when you get your echo reports, you at least know what numbers are important. And if certain metrics or certain parameters are not mentioned on your report, more importantly, you can politely inquire with your cardiologist or whoever it is who's performing your echocardiograms to give you the required information. When we were planning this, both Shalaka and I understand that most of our patients, if they are not in a tier 1 city, they would be getting their echocardiograms in smaller diagnostic centers where you may not even have a cardiologist performing and interpreting the echo. It may be an MD medicine physician, which is absolutely fine. We just need to make sure that there are certain parameters that are there on the report, and the whole idea of the session is to make sure that these numbers are there, and we are, as basically we take more ownership of our diagnosis and management, and we try to keep track of these important parameters. So, when you look at an echocardiogram for pulmonary hypertension, the most common thing that comes to mind when you look at the report is, what are my pulmonary pressures? All the patients are always looking at what my pulmonary pressure are. So generally, in about 90-95% of the cases, you will have an estimated PASP, a PA systolic pressure. PA, everyone knows, is the pulmonary artery. So, and then there would be a number of 40, 80, 100, whatever it is. So that number is, the most easily accessible. I think if you look at most of the echo reports in the community, you should at least have that reported on you. Needless to say, it tells us, obviously everyone knows the higher that number is, the worse your disease severity is, but it's not as simple as that. In advanced stages of pulmonary hypertension, the PA pressures, the pressures in the artery actually go down simply because the right ventricle is now so tired, and it becomes weak, so it's not able to generate that pressure across the pulmonary artery. So merely looking at that number is not the be it all for echo reports. So in addition to that, we have to look at other metrics. Now, some reports would also talk about a PA diastolic pressure, a PADP. Some reports will also talk about a MPAP, which is a mean pulmonary artery pressure. Now, for all practical purposes, the number which is most strongly sort of authenticated and validated on an echo model is the PA systolic pressure. The PA diastolic and the mean PA pressures are okay parameters, but they should be correctly done. So, often I see that, the reports may have it, but they are not very accurate. So for practical purposes, if we just focus on the PA systolic pressure, that is good enough, provided it is accurate. And, I already mentioned the caveat about how in advanced stages, the PA pressures may not go up, or it may actually come lower than what you have usually, but the right side is failing. You will have right heart failure with lower PA pressure. So PA systolic pressure is not the whole thing. Now we look at certain other things. Now, certain other thing is we look at the size of the right side of the heart. We know that because of the pressures in the pulmonary artery, which connects the right side of the heart to the lungs, all the back pressure changes, all the brunt of all the pulmonary hypertension is borne by the right ventricle. Now, the good God has not made us in such a way that the right ventricle is not able to tolerate such high pressures for a very long time. And so naturally it starts failing, it starts to show certain changes. So the echocardiogram is what we are doing with serial echocardiograms. It's trying to see how healthy or unhealthy the right ventricle looks. So in the beginning, most of the patients will have an enlarged or a dilated. So dilated is the technical term, dilated right ventricle and a right atrium. How big it is also something that is very important. So, and for all of these metrics, it is not one single number, it is the trend that we have to look at. At diagnosis, depending on how early or late you are diagnosed, that number may be significantly abnormal, or it may be normal, or it may just be mildly abnormal. But the more important thing is that once you are started on therapy, you should start seeing some decrease or some actually improvement in the right ventricular and the right atrial size. On the flip side of it, if the right ventricle and the right atrial size continues to increase despite you being on good therapy, then that's a sign to worry. I don't think you should know about, what the cutoffs are for what is the normal right ventricular size, what is the normal right atrial size. I don't think as patients you need to be worried about that. I think, again, don't be worried about numbers, look at the trends. Same for PH systolic pressures as well. Don't be too much fixated about the numbers, but look at the trends. See what your numbers were 6 months before and which way we are progressing. The other thing that we look at is the valve on the right side of the heart, which is called as the tricuspid valve. As the size of the right side of the heart increases, so naturally this valve here, see, when the size is this much, it's able to meet in the center, and it's able to prevent any backflow of blood back into the top chamber of the heart. As the size of the right ventricle increases, then you see there is a stretch on these valves. My thumbs are the valves, and they are not as well able to coapt or to meet in the center. So that leads to increased leakage and increased pressures in the right top chamber of the heart. And up to a certain point, then in certain patients, the valves don't even meet. And, that would lead to just severe torrential leakage of blood into the right top chamber of the heart. And that goes along with the increase in size of the right ventricle and the right atrium over a period of time. Now, moving on, other changes that we see on the echocardiogram is we try to quantify how good or bad the right ventricular function is. Now, here is where you really need to be in a good center to with a good sort of an echo machine, echo software to get minor details. Most of the basic centers will give you a number called TAPSE, TAPSE. I would say about 50% of the centers would give you an S dash number, and another, I would say 5 or 10% would give you a RVEF, which is a right ventricular ejection fraction. Very rarely, maybe 2-3% centers may give you a right ventricular strain number. So all of these are very technical numbers. Each one comes with its pros and cons. None of these, I would say, I can't single out one number and tell you, look, this is the one that will tell you the most about your right ventricular health. It's everything put together. Now, for instance, your TAPSE, which is generally, the most common metric, as I told you, that's available. Your TAPSE is actually, if you look at other patients, non-PH patients with right ventricular failure because of heart attacks or because of cardiomyopathy, the TAPSE number in PH patients tends to be preserved for a much longer time as compared to the non-PH patients who have right ventricular failure. Now, this is because of a very, sort of a technical scientific thing that it's difficult to explain to you, but it's something to do with what we call in the cardiology and PH world, right ventricular and PA, pulmonary artery coupling. So what basically this tells us is how the right ventricle and PA relationship is. And to sort of decipher that, there are several other sub-metrics that we look at. Again, I don't think we should be focusing on all of those now. The bottom line is that none of these single numbers are important, but you should make sure on your report you have at least one of this. Even if you have at least one of this, and again, if you're keeping an idea of the trend, maybe it's the TAPSE, is the RVEF, or it is the S prime number, at least one of these numbers should be there on your report. And if you don't see this, very politely ask the center or the cardiologist or the physician about that number. It's not very difficult to get at least the TAPSE and the S prime number. Even the basic machines should have it. then sort of as we move on from this, then we are looking at other features of, just markers of how congested the right side is, the right side of the heart is. So we look at how it's affecting the left side of the heart as well. In very, very, very extreme cases, the right side of the heart becomes, bigger than the left side of the heart, which is not normal, which is not physiological. So it tends to, as it's growing, see, the heart is going to, it has a fixed space. As the right ventricle grows, it's going to grow at the expense of pushing the left ventricle. So it pushes the whole wall between the right and the left side to a certain part. And, so then we start seeing certain changes. So you may see on your report that there is septal flattening or a D-shaped ventricle. These are certain technical terms that we use. These indicate that the pressures in the right side are extremely high, and that the right side is really pushing the left side over. And then there are other certain soft metrics that we look at, like the size of the pulmonary artery also is extremely important. Now, I have left out one very important sort of population of patients here. That is the ones that are born with congenital heart defects, like the holes in the heart, the atrial septal defects, the ventricular septal defects, the coarctations, the PDAs, the patent ductus arteriosus. All of these patients, they can have pulmonary hypertension, and their reports, in addition to having all of what I mentioned, they may mention about their underlying congenital heart problem, which may be the heart, the hole in the heart, or the extra shunt. So again, we know that there is, in all of these patients, we know that they have been diagnosed with pulmonary hypertension because of the congenital heart defect. We know that once you're detected with a certain degree of pulmonary hypertension, correcting that underlying heart defect is not going to help much. So in that case, we are not focusing more on the underlying heart defect. It is all what we are focusing on is the pulmonary hypertension and its effect on the right side of the heart. So those things. And another very important indicator which tells us about the prognosis in pulmonary hypertension is presence of pericardial effusion, which means fluid around the heart. In severe cases of pulmonary hypertension, because of increased pressures in the heart, there is some amount of fluid accumulating around the heart, which by itself is not, it doesn't cause hurt or pain or anything. But we know that in large trials, we know that the presence of that pericardial effusion tends to give a much poorer prognosis as compared to ones who don't have pericardial effusion. So I think I have mentioned all the points. Shalaka, if we want to discuss any questions on this topic.
Yeah. Doctor, so, just to summarize, which are the top 5 factors, parameters that need to be mentioned on a 2D echo report for us? What would you say?
So these are the minimal things that should be present. PASP, which is the pulmonary artery systolic pressure. The presence or absence of tricuspid regurgitation, TR, and how much it is, meaning the leaking across the valve, whether it is mild, medium, or severe. The size of the right side of the heart.
RV and RA both.
At least an RV would be helpful.
Okay.
And at least one of the parameters of either TAPC, S prime, RVEF, or the RV longitudinal strain. So either one of these parameters should be present. So those were 3, and then presence of pericardial effusion.
Right, very important. Yeah.
Yes.
And in, a lot of patients do not get the echoes done at the same center sometimes. Do you think they should, always ensure it's at the same center?
Agree. I think wherever you get it done, unless you're not at all happy with that center, you should ideally try to do it at the same center, because, there is, truly speaking, there's a lot of subjectivity to how echoes are being reported. Even myself, I may look at an echo today and I may look at it a week later. There may be sort of a subjective variation in how I report something. So that's why, we as cardiologists and interpreters as well, we try to rely on these objective numbers, like I told you, the TAPC number and the RVEF number. These helps to take out that subjective bias in our mind. But, it's important when if I as a cardiologist am reading an echo and I feel that no, Shalaka, your echo, just for example, Shalaka, that it looks much worse, I would actually be able to pull up the previous image and put them side by side and compare and even show it to you that, listen, Shalaka, this is what is looking worse. So these things are very important when you have serial follow-up at a center. You know that it's the same machine, same technician, same reader who's saying that thing. So you need to take it more seriously than you would otherwise.
Okay. And doctor, when you're establishing a diagnosis of pulmonary hypertension and when you do not have a recourse to a right heart catheterization, again, are all of these important, the parameters that you mentioned, important establishing it, or is there like one very definitive?
So if you do not have a diagnosis of pulmonary hypertension and this is your first echo, then actually the echo becomes even more important because it will give you telltale signs of what kind of pulmonary hypertension you have, whether it is pulmonary hypertension because of the heart problems itself, whether it is pulmonary hypertension because of the stiff heart or some valve disease or something else. So, all the parameters that I mentioned are important, but in addition to that, we have to look at very carefully at the left side of the heart, because in India, still what we see as adult practicing cardiologists, the most common type of pulmonary hypertension is because of problems in the left side of the heart. So, the echo over there is extremely important. And I'm sure this question is going to come up, but, our guidelines, the European and the American guidelines always mention about performing a right heart catheterization. Listen, the basic reality is that most of our patients would have never had a right heart catheterization. So that makes the echocardiogram even more important. Whether or not right heart cath is required or not, that's a completely different topic that we can talk about for another 2 hours. But that makes the echocardiogram even more important. So we have to treat this very respectfully and make sure that all the parameters are there.
Right. Doctor, you mentioned CHDs, but what about autoimmune patients or even lung disease patients, especially ILDs, when they develop an ILD? Are there any extra parameters that they need to be careful about?
Not really. I think even in both the subset of the autoimmune, like say the lupus patients or the the systemic sclerosis patients, I think in all of them, and there's nothing else that comes to mind that would be different. I think the echo is again telling us about the heart health, and that is all an indicator of what's happening in the pulmonary artery. So yeah, I don't think there is anything different that we need to look at.
Okay. Is there any particular reason why there's no standardization, how these test reports are generated?
So even at large sort of Western countries, if you go from one university to another, there would be changes. We have a centralized body, say in US, you have the American Society of Echocardiography. Similar, we have something like that in India. But unfortunately, they prescribe that certain minimum things are to be mentioned on the report. But unfortunately, especially in India, there is no sort of guideline on what should be there or what should not be there. It's not standardized at all. And also it depends on who the reader is and what's their style of reporting. Bottom line is there is no standardization because there is no I would say minimum prescription. So like in US, your echo should have so many points to be billed. And there are different levels of echocardiograms. In India, we do not have that. I can write 4 lines on the echo report and get the same amount, charge the same amount as when I write 2 pages on the echo report. So there is no standardization in those regards.
Okay. Doctor, how often do you think we should do our 2D echoes?
It depends from patient to patient. After diagnosis, I think once you're initiating some kind of therapy for the pulmonary hypertension, I like to do it at the minimum, at least every 3 months or so, unless there is a change in the clinical situation.
Okay.
If the patients are steady on some kind of pH therapy and they are showing improvement in their other parameters, such as the 6-minute walk distance, and they themselves are reporting an improvement in their exercise capacity, then I may push that follow-up scan to every 6 months or so. But at least in the initial period, minimum would be every 3 months or so. Remember, we are not even doing right heart catheterization. So, we as cardiologists or, pulmonary hypertension specialists need some more information to help us manage.
Okay. I think, Doctor, we've covered enough and most important aspects of 2D echoes in PH. If there are any questions about this subject, please send me those questions. I am getting questions on the other topics, but I will defer them for later. If there are any questions specific to the 2D echo aspect of our disease management, please let me know. Doctor, I mean, with an RHC, just in comparison to an RHC, what extra information are you getting from an RHC? If you could just tell me, like, very briefly.
So the RHC actually is giving you the numbers that the echo is trying to estimate. So it's when we mention on the echo report, we always mention the estimated PA pressures are. So the RHC is actually giving you the real deal, what the truth is in the pulmonary artery. It also tells us how badly the right side of the heart is doing by giving us additional numbers about the pressures in the right side of the heart.
Okay.
Most of the larger studies that we know about, base their therapies on the right heart cath numbers as opposed to the numbers on the echocardiogram.
Right. And doctor, is there any particular time you should or should not do an echo? Like if you're already, not doing well on a particular day, should you avoid doing an echo or?
No, so it depends on what you're trying to look for in the echo. If you're doing poorly, and as a treating person, I may want to know, what's going on, meaning are the pressures bad, how much fluid there is it mostly fluid that I need to take out or work more on, the pH medications. So those indicators would tell us. So it's not that if you're feeling poorly, you should not do it. You're afraid that the report was not be as good as, it was last time. It is all about, why you're trying to do the echocardiogram.
Okay. There's a question on what about RV fact?
RV?
Fact, FAC.
Fractional area change. Yes. So,
yes.
Thank you. So, yes. So I do that very commonly, and actually that is a number which is very easily available and can be done even without advanced software. So that is something that is also equally important. So I would add that to the TAPC S prime, fractional area change, and the RVEF and the strain pattern. So definitely, so TAPC, S prime, and fractional area change, these three ones can be obtained on any basic echo machine.
Okay, all right. There's a question: are there major differences between PA pressures calculated on an echo and an RHC? Are the RHC numbers higher or RHC numbers lower?
So there is no data which tells us consistently that the RHC numbers are more or less. But in our clinical practice, we've seen that they can be, vastly different. Both on the lower side and the higher side. To be honest, most of the times the right heart cath pressure numbers are higher than what I get on the echocardiograms. Most of the times. Only rarely, I would say about 2-3% of the times I would, I would be surprised and say, oh, really, the right heart cath, the PA pressures are not as high as they were on the echo.
And how much higher are we talking about? 10%, 20%?
I would say at least 25-30%.
Oh, okay. All right. So this also then changes how you classify your patients?
It changes how I
The risk
classify it.
stratification.
Exactly. It changes the prognostication. So, the risk stratification and what kind of pH therapy we are aiming to give to the patient.
Okay. I think we should close this topic and move on to our next session. Thank you, Doctor. I hope, everybody who's joined us today has learned a little bit about 2D echoes. And I think we're going to share a notes in our patient support groups after this. Everybody's going to share.
Chalaka, you'll have to summarize all this and...
I will. I will. Okay, so let's move on to our next session. This is on heart failure. And let's talk about symptoms which patients commonly feel but cannot pinpoint the reason for it. And a lot of times we delay reporting these symptoms to our doctors, but these are actually symptoms that indicate heart failure. And Dr. Talha Meeran, let's talk about the early stages of heart failure and some of the symptoms, their establishment, their progression, and how to manage them. Over to you.
All right. So, the most, in advanced cases, you obviously have signs of right ventricular failure, which can be anywhere from just a mild swelling in your legs to just significant swelling in your legs, your abdomen, the belly area, severe shortness of breath, severe exercise intolerance, episodes of recurrent unconsciousness or loss of consciousness, which we call syncope, especially if they are exertion related, or episodes of near syncope where you almost feel like you've had a blackout but not quite so. And then in milder cases, initially you may just have a little bit of shortness of breath with ordinary activities, or less than ordinary activities as well may give you a little bit of shortness of breath. In some cases, patients do have a little bit of chest pressure or chest pain in the whole chest area. It doesn't necessarily have to be in the left side. It can be right-sided. It can be in the center. It can be anywhere. Now, the reasons why patient can have chest pain. Now, this chest pain, I need to make sure that you all understand, is different from the regular angina or the heart attack chest pain that we all know about and is quite commonly portrayed in the media. So what happens in pulmonary hypertension is that because of increased pressures in the artery, in the pulmonary artery, the right side tends to become larger, and more importantly, the right-sided wall becomes thick. As I told you, the right side, the right ventricle, is not built to face such pressures and to handle such pressures. So as a sort of a physiological way to tolerate those pressures, it tries the walls become thick. When the walls become thick, they obviously demand more blood supply, because look, I have more muscle now. I need more blood and more nutrients to keep up with this. So the workload, or the sort of the oxygen and the nutrient demand of the heart increases. And whenever there is a difference between the demand and supply of oxygen and nutrients to the heart muscle or any part of the heart, that can give you chest pain. So in pulmonary hypertension, that is, I feel, is the main reason for having chest pain. Other common things could be just having increased pressures in the heart. And another common thing, especially in our patients with chronic thromboembolic pulmonary hypertension, where there are blood clots in the heart, but they've been there for a long time, having new blood clots on top of the old blood clots can give you new chest pain as well. Patients with lupus, these mixed connective tissue autoimmune conditions, they also tend to have a lot of chest pain because, basically it's an autoimmune condition which causes inflammation everywhere. So it can cause inflammation at any given point in the body. They have joint pains, they have small joint pains in their hands and everything. So going along with that, they can have inflammation along the cartilages that connect the center breastbone to the ribs. So they can have a lot of inflammation of that, and that can give you chest pain. Lupus patients can also have inflammation of the outer layer of the heart, so the pericardium, and that is something called as pericarditis. So that can also give you chest pain. Common for the most common kind of pulmonary hypertension that we have, the group 1 pulmonary hypertension that we have. When they have chest pain, it is because of the increased pressures in the heart and because of that demand supply mismatch. And generally, it is an indicator of how your disease is doing. Say patients have chest pain, started on medical therapy, their symptoms got better, and now suddenly after 2 years you are having again more chest pain. So generally I've seen that shows that maybe your pH is the disease severity is getting worse.
So as far as chest pains are concerned, they can happen central part of your chest as well as left side as well as right side.
Correct. Yeah. So the anginal chest pain is mostly on the left side, but this can happen anywhere, center, left, right, anywhere.
Okay. Okay. Let's talk about swelling, doctor. Abdominal as well as
yes. So, see, the abdominal and the leg swelling happens at a much later stage compared to chest pain. And Shalaka, we need to talk about cough as well. So, so we'll talk. Yes. So remind me about that. But
yes,
as compared to cough and chest pain, this abdominal and the leg swelling is sort of a much later event. It generally tells us that the pressures in the heart are high, and now that's causing some kind of overload on the right side of the heart that gets reflected on the liver, which then gets reflected in the belly and in the lower legs. So, basically it will happen in all the dependent areas. Some people who are mostly flat in bed, supine, lying on their back, they tend to have more swelling just above the buttock area in the sacral region, what we say, in addition to what you see in the belly. And obviously the leg swelling, which starts off with swelling in the legs, in the feet and the ankles, and then they build up. They sort of, the levels rise as the amount of congestion increases in the right side of the heart.
And this swelling usually occurs proportionately with a weight gain, right?
Correct. So a way to monitor the swelling for us is looking at the weight. As the weight increases, we assume that it is because of the fluid weight increasing. That may always not necessarily be true, because in advanced cases, we know that, how there is outward visible swelling in the abdomen and the leg, there is inward invisible swelling in the stomach and the intestine. So patients don't feel as hungry, their appetite goes down. And so, at one side, you are increasing and gaining fluid weight, but on the other side, you're losing muscle mass and you're losing muscle weight. So patients may say, look, doc, I have not gained any weight, but I still have more swelling than what it was 6 months ago.
Okay.
So, yeah, so it could be a mix. So muscle weight and fluid weight, there are two things that you have to look at.
Okay. Doctor, what about palpitations?
Right. So palpitations, again, you can have it at any stage. It is basically what is palpitation? Palpitation, just to make sure everyone is on the same page, is basically an abnormal awareness of your heartbeat. Normally, awareness. Yes. Normally, patients do not, normally as an individual, if you talk to a normal person and ask them, look, do you feel that your heart is beating? They would say, no, not necessarily. But, sometimes patients have an abnormal increased awareness about the heart, and that is about the heartbeat, and that is called as palpitations. Now, the most common reason for having palpitations for pulmonary hypertension is, the stretch on the right side of the heart can trigger heart rhythm issues. And that can cause transient increase in the heart rate. And that can be perceived as palpitations. Sometimes the medications that we use to get rid of the excess swelling, they can cause a lot of electrolyte shifts, like low potassium, low magnesium levels. All of this can also trigger rhythm issues, heart rhythm issues, where the heartbeat can go up transiently, and that can also be perceived as palpitation. So it is always something that you should not ignore. You should immediately report it to your treating physician, because they may need to make some changes or do some easily done blood tests to cover the causes and adjust the medication. It can be something that can be easily fixed. So don't hesitate in reporting palpitations.
In fact, palpitations happen to be one of those symptoms that we all, just accept. This is how it's going to happen, and we never report them because we think that this is just common to PH and let's go on with it. Especially in the nights, it happens mostly in the nights before going to bed.
No, I mean, so it may be something that you may have to live with. That I'm not denying.
Yeah.
But if it's a new symptom, and or if it's something that you had before had subsided and now it's coming back again, it's worsening in frequency or duration, you should report it immediately.
Okay. Doctor, let's go to a very perplexing symptom here, which is dizziness, fainting, syncope, pre-syncope.
Right. So
I heard we talk about it.
Yes. So this is extremely important whenever I talk about pulmonary hypertension, even amongst my fellow colleagues or the general physicians in the community. I always make sure I drill this into everyone's head, not to ignore dizziness and these lightheadedness and sort of pre-syncope, what we say, or just before you pass out kind of a feeling. This always is an unwanted sign in pulmonary hypertension. This means that the right side of the heart is really crying out for help. It's not getting enough blood supply, and or it's become so big that it's compressing the left side of the heart, and as a result of that, the left side is not able to pump enough blood to your brain. And that is causing these passing out and dizziness spells. So if you look at our medical literature, having even one episode of unexplained syncope, meaning loss of consciousness in the presence of pulmonary hypertension, immediately puts you up 2 to 3 grades in the risk stratification stage. You immediately become a severe PH. So again, therapy that we offer changes drastically. Generally, syncope happens or loss of consciousness happens when the pressures in the lungs are so high that the right-sided pressures are above the left side, are over the left-sided pressures. So generally, in advanced cases, minor symptoms of dizziness, lightheadedness could be sort of a prequel to this the severity worsening. So again, there is no reason to ignore this. Another common reason could be too much water being taken out, because the Lasix or Diator that we use to get rid of the swelling, if we are using it too much, even that can cause dizziness, lightheadedness. So this is more commonly seen in patients who are on long term of these diuretic pills, where as treating physicians, we need to understand that beyond a certain point, now this right side of the heart is actually used to much higher pressures, and if we try to aim for normal pressures, we may never achieve that. In that aim, we may end up hurting the kidneys and causing stuff like dizziness, lightheadedness. So whenever someone reports to us about dizziness, lightheadedness, these are the first things that we do, making sure there are no rhythm issues, making sure electrolytes, your potassium, magnesium is okay. And then, we do an echo and we see that there's a big right side pushing over the left side. So those things, then come into picture.
So, Dr. Talha, so dizziness, fainting is not about low BP, right? Because often what we see is patients react to these things thinking it's low BP, and then immediately have something sweet or Nimbu Sharbat or something like that. And that's not going to solve the problem, is it?
So low BP is one of them. See, what is happening is the left side is getting completely squished. So the left side being squished means that there is low blood flow out of the heart, meaning your blood pressure, if I recorded at that time, will be low only. But the treatment for that is not, having Nimbu Pani. In fact, it is relieving the congestion on the right side of the heart, which may be giving you Diator and Lasix to take that congestion off. So I mean, at home, there is nothing more to do than have a glass of water. It's fine. One glass of water is not going to hurt you. Or one glass of nimbu pani is not going to hurt you. But the more important thing is you report it to your physician and try to see them as soon as possible. If someone tells you that, okay, you see me next week, I'm too busy right now, you go find another physician, because syncope
This is
should never.
something that needs to be
This is
reported immediately.
extremely important.
In fact, I would say even the swelling in the ankles and abdominal is something that needs to be reported immediately, right? Do not
Correct.
wait for it.
Correct. I mean, but again, it's not something that can be immediately life-threatening. The swelling,
Okay.
this can be life-threatening. Passing out, dizziness can be life-threatening.
Okay. Okay. Doctor, let's go to shortness of breath.
Correct.
And yeah.
So shortness of breath, I'm sure everyone over here is, very, very familiar with that. Shortness of breath is possibly the most common and the symptom that comes on the earliest in the disease course. As the disease course worsens, the shortness of breath also can get worse. You can be short of breath just by, doing at initial stages, just while doing very heavy exercises, climbing stairs with a, bag in your hand. Or, as the disease progresses, you tend to become short of breath even with, simple activities of daily living, like taking a bath, changing clothes, taking a shower. Even that becomes difficult. And in the extreme advanced stages, you tend to be short of breath even speaking long sentences. So all of this basically is simply because of the pressures in the lung and the increased pressures in the heart. There is nothing more or less to this. Needless to say that, if you are having shortness of breath which is worsening, you should not again ignore this. You should tell your doctors. Again, it's not something that can be, immediately life-threatening, but it may be something simple that can be tweaked around. If you have shortness of breath with increasing leg swelling, then maybe your doctors will increase your fluid pills, your Lasix or your Ditor dose, to help you see how you are feeling.
Okay. All right. Doctor, a very important thing that people in advanced stages of pulmonary hypertension have been reporting is changes on the skin and on the nails. So let's talk about that a little bit. Let's start with the skin first.
So changes in the skin, I have seen mostly in patients with the autoimmune conditions. The lupus patients tend to, have certain typical kind of rashes, and so as the patients with the systemic sclerosis. Otherwise, in the other kinds of pulmonary hypertension patients, I've not seen this very commonly. What we have seen is just darkening in the legs.
Yes, that one. Yeah.
In the lower half of the legs. That is because of continued swelling in the lower legs, which tends to sort of cause damage to the veins in the legs, and the veins themselves start becoming leaky. And when they leak, it's basically a part of the blood pigment that's being left behind, and it's causing that blackish kind of discolorations in the lower extremity. So that is the most common thing.
Patients often, or maybe the doctors also, when the doctors are not PH specialists, they mistake this for DVT. So is it DVT?
No, not at all.
It's not, right?
No, it's not at all. DVT is clotting in the veins of the legs. This is different. This is swelling in the veins, excess fluid in the veins, to the point that there are small valves within the veins that get damaged, and they become leaky, and they just leak out everywhere.
Okay. What about nails, doctor?
So nail changes, to be frank, I have not seen it much here.
Clubbing?
Yeah, okay. Clubbing may be one of the nail changes. We consider it more as just as a general medical examination. Yeah, so clubbing could be seen. Again, more in patients who are requiring oxygen. So more commonly in patients who have congenital heart problems, holes in the heart and whatnot. Also seen in patients with very advanced lung disease related pulmonary hypertension, where for whatever reason they are requiring oxygen for a long time. So basically, clubbing is a response to low oxygen levels at the capillary level. They stimulate extra blood vessels, and some places they are more apparent, so like the legs. So some congenital heart disease patients tend to have clubbing more. Special, subgroup of patients tend to have clubbing more in the legs as compared to the hand. So even that can
That can
differ.
happen.
Clubbing
Okay.
is basically for everyone to know what is clubbing. Everyone may not have clubbing.
Yes, please.
So clubbing basically is swelling of the tips of your fingers. Like we used to call them hot potato fingers or something like that. Basically they look like big clubs. Like the remaining part of your fingers will be skinny. It is only the tip of the fingers that will become thick. And they're generally not painful. And they're generally not red or anything. They'll just be big. And if they're associated with other low oxygen conditions, then they may turn blue when you are exerting yourself.
Okay, doctor, there are some questions on this. One of the patients is mentioning brittle nails and ridges on nails. Is that related?
Not really, but it could be related to important nutritional deficiencies, which could be a consequence of long-term pH, not eating the right kind of diet, not absorbing the nutrients because of swelling in the stomach. That can cause nail discoloration, ridging, and brittle nails and all of that.
Have you also come across dry skin issues?
Yes. So I'm not sure why, but the PH patients do have excessive dry skin issues, but not to the point that, they need to see a dermatologist. I have never come across that. Generally, they get better with just stronger lubricating creams.
Moisturizers,
lubricating creams.
Okay. Can we take a few questions on this subject, doctor? Yeah.
Sure.
So there's one question on what kind of chest pain should be immediately reported. What's the difference between heart attack chest pain and PH chest pain? I think the second part is answered. If you could mention,
So what was the first part? What kind
of chest pain should be immediately reported?
So chest pain, which is new, which is completely new to you, and you've already been suffering from PH, and which is completely new, you should definitely report it. Patients with chronic thromboembolic pulmonary hypertension, the ones with the blood clots in the lungs, if they are having new chest pain, you should report it. If you are having chest pain, say you've had chest pain for some time, but now this chest pain is different in a way. Maybe now you have chest pain with dizziness or chest pain with worsening leg swelling. So, chest pain with something else or any other change in your clinical symptoms, you should definitely report it.
Okay. There's a question on, is new pain on the back of the heels and dilated veins a symptom of heart failure? Back of the heels pain and
dilated veins in the heel?
No, on the legs, but heel pain. And heel pain is something I've heard from a lot of patients.
Heel pain may be because of the swelling part only, but dilated veins again may not necessarily be due to them having congestion now, but maybe as a consequence of long-term congestion. I told you that the veins become damaged and they can become leaky and they will be dilated. So a lot of our patients, because of long time suffering from right ventricular failure, they tend to have varicose veins, which is leaky veins in the legs.
Okay. There's a question on how many episodes are too many in terms of fainting, and
one.
Do we report? Yeah, one, right? And do we report the lightheadedness itself, or do we wait for the fainting to actually happen, blackouts, and then report them to the doctor?
No. We don't take lightheadedness, dizziness, or fainting at all lightly. We don't at all. So you have to. One episode is enough because that one episode will be your only episode in your life. So you have to consider it like that. It is extremely, extremely serious. Nothing to be taken lightly. In those regards, it should not be taken lightly.
Okay. Would immediate oxygen support help in these situations?
It may help. So it is one of the few things that you can do at home immediately to sort of help calm the patient down. So if you are, if you can drink something, nimbu pani, that's fine. Giving oxygen is fine. All those things are fine. It won't hurt.
Okay. It won't hurt. Okay. There's a question on chest pains again. Can they be felt all through the chest till the back, or especially just the left to sternum?
So no, again, see, because the reason for the chest pain can vary depending on what your diagnosis is. just having regular pulmonary hypertension itself, it's the lung arteries are on both sides. It's not that it is on one side only. So you can have chest pain on either side. When you have chest pain due to this pericarditis, I told you the patients with lupus can have inflammation in the outer covering of the heart. Their chest pain usually goes to the back of the to the back, and sometimes they can be positional in nature too. Like they would be better in certain positions, they may be worse in certain positions. So those would vary. The chest pain due to angina is mostly on the left side of the heart, mostly during exertion, and can be radiating to the jaw, shoulder, and the left arm. You generally do not see that in pulmonary hypertension. The pulmonary hypertension chest pain can happen even at rest.
Okay. So there's this is a very important question. Dizziness and lightheadedness while getting up from lying down or sitting and never otherwise is related to heart failure. Is this related to heart failure? Like I'm sitting and now when I get up, I may feel lightheaded, or when I'm bending, I feel lightheaded.
No, so that is something that is expected because of the medications that you are on. The medications that you are on, they tend to cause these positional changes in the blood pressure. I wouldn't say all of them, but most of them would cause that. So whenever you are making changes in position, make sure you give yourself an extra 5-10 seconds before you start walking. Say you've been sitting for 2 hours watching a movie and you suddenly get up, give yourself extra 10 seconds before you walk.
Okay.
That is expected. I won't say it's a side effect, it's an effect that your medications have.
Okay, I hope we've covered everything among the symptoms for heart failure. So these are symptoms of progressing heart failure, right? And could you take 2 minutes to speak on the spectrum that heart failure, and that it is not the end of life situation, please?
Right. So whenever someone develops heart failure because of pulmonary hypertension, it is not, as Shalaka was saying, it's not a death sentence. You have a lot of options right now to try to improve how you are feeling and how your heart is doing. Thankfully, and thanks a lot to what PHI is doing, we have more easy access to a lot of other medications in the last, say, 7-8 years in India. And so heart failure does not mean that, you are going to die in the next 3 months. You have a lot of medication options. You have lots of now even surgical options short of transplant to support the patients. So don't at all resign to fate when you're told that you have heart failure.
This is something that your community of doctors needs to take up, right? The terminology, and which scares the patients. It's not heart failure, it's heart failing and probably improving as well over the years.
So, I've been struggling with this because, in my title, I call myself a heart failure cardiologist. So in my title too, it's right there. And even so, when we started a heart failure clinic here in this hospital, I actually made it a point not to name it a heart failure clinic. We call it a heart rejuvenation clinic, because that's what we want to do. It is for heart failure patients, but our target is to rejuvenate them. So we actually renamed it and called it a heart rejuvenation clinic.
Yeah, because the very fact that the rejuvenation is possible is hopeful for us.
Correct.
Heart failure in itself is a very scary prospect, and the battle is lost right there with the terminology.
Unfortunately, my title still remains and it can't be changed. So.
Rejuvenating failing hearts. Something like that. Okay, doctor, we should go to our next and final topic, which is managing persistent cough. It's a very distressing symptom, impacts psychological, social lives as well. Could you say something about it? And we've crowdsourced questions on the subject and from all the patients.
Right. So, I must admit, Shalaka has been really requesting me and behind me for at least the last 1.5 years to talk about just about cough, just about cough, because I know it had troubled her during her initial days. Right now, she's with us talking for the last 1 hour without a single cough, so she's doing better. But cough is very annoying and common symptom. So PHI, I think, had reached out to some patients to ask them about their cough, and I went through all the responses. The patients were asked to report how often they get cough and to describe the details about their cough. I would say nearly, I would say 65-70% said that they've had cough at some point or the other. Very rarely someone said that they've not encountered cough at all. Now, the mechanism for cough, if you try to think of it from a scientific basis, it's not very clear, really. I myself had to do a lot of digging around to figure out what's causing this cough. Cough in patients with lung disease related pulmonary hypertension is accepted, it's expected, and there's a completely different sort of treatment for it. But cough in patients who do not have lung disease and simply have pulmonary hypertension from whatever other cause other than lung issues is something that was really, I also didn't know. But after a lot of digging and sort of things, we found out that, what basically triggering the cough is, again, it all comes down to the swelling in the right side of the heart. The swelling in the right side of the heart actually sends out chemical signals which releases a lot of inflammatory mediators in the body. Those inflammatory mediators can irritate the airways and cause this sort of constriction and cause cough. So that is, believe it or not, what most of our medical literature tells about cough in pulmonary hypertension patients. Other common causes being having fluid in the lungs. Now, this is another very important thing that you must understand is the pulmonary hypertension that we are discussing today, the group 1 pulmonary hypertension, because of increased pressures in the lungs, they generally should not have fluid in the lungs, okay? Because it's not, the fluid in the lungs is because of a problem in the left side of the heart. The pulmonary hypertension affects the right side of the heart. So generally in patients with pulmonary hypertension, you should not have left-sided heart failure. Hence, you should not have your lungs filling with fluid. If you are on pH therapy and your pH therapy is actually causing more cough as the doses increase, then that means that you definitely, number one, should tell your treating physician about this. There may be a component of pulmonary hypertension that we are missing. The medications may have unmasked some kind of stiffness on the left side of the heart, which was not previously known, that's causing this. Or you may have a very rare disease problem called pulmonary veno-occlusive disease, which can be a great mimicker for the garden variety of pulmonary hypertension, and can be extremely challenging even us as physicians to diagnose. So when you're having cough and the someone is telling you that you have fluid in your lungs, then don't take that as a simple answer, because with pulmonary hypertension you should ideally not have fluid in your lungs. So fluid in the lungs and the inflammatory mediators causing the cough are the two main common things why I see patients have cough in pulmonary hypertension. Generally, again, I've seen that as the underlying disease severity worsens, the cough also increases. There are certain medications which actually cause acidity and acid reflux, and acid reflux can sometimes cause cough, a very nagging dry cough which gets worse in the nighttime when you sleep. So that's something that we can easily fix. You can give antacids or maybe change one medication to another to try to see if the acidity comes down and the reflux improves. That can also be one of the treatment parameters that we can employ for this nagging kind of dry cough.
Doctor, what about medications? You had once mentioned ambrisentan could be a culprit.
So that's what ambrisentan is. I didn't want to name any medications because everyone over here would start reporting a dry cough, because I'm sure most of them would be on ambrisentan. But yeah, so ambrisentan very commonly causes acidity, about 15 to 20%. They do have acid reflux. So, maybe switching to another medication in that same class may help the patients if they are not improving with antacids and acid, regular acid reflux preventive measures.
Okay. Doctor, besides this, how do you manage? I mean, a lot of patients manage this, the persistent coughing with cough medicines. Should that be okay?
I think that's perfectly reasonable. There is
OTC cough medicines, okay?
Yes, I mean, so it's difficult. In India, you cannot say OTC anymore, right? I
Yes.
mean, everything is over the counter. So if you're using just simple cough suppressants, they are okay. Don't use too much of codeine, which
Okay.
ideally you should not get over the counter, but in India, you can get everything over the counter. So too much codeine is not good. And otherwise, simple cough suppressants are okay. If that's not getting better, I've seen some patients strangely get better with short courses of steroid inhalers.
Okay.
Again, this may be signaling the fact that truly there is inflammation locally in the airways, and when you take the steroid inhalers, that's directly targeting the inflammation in the airways and trying to
So
get better
is
with
this an allergic reaction your
sort
body's
of.
having, or what is causing the inflammation?
So because of the pressures in the right side
Pressures,
of the
okay.
heart, that is causing the inflammation, and that's what's releasing the inflammatory mediators.
Okay. Okay. And any other way to manage cough?
No, I think acidity, medication changes, so that, and if that doesn't help, then I generally send them to a pulmonologist, and they get better with a short course of inhaled
Inhalers, which are usually steroidal, right?
Yes, yes.
In nature. Oxygen, how about oxygen? Does that help?
If you have low oxygen levels, yes, low oxygen levels can themselves, trigger cough in pulmonary hypertension patients. But generally, I don't think giving oxygen helps if you already have normal oxygen levels at baseline.
Okay. I think, Doctor, we should now open to questions the last 5 minutes. I will just take up the questions already posed to me. There was a question on can detour help in cough?
Can what?
Detour, D-E-T-O-U-R.
They may mean Ditor, D-Y-T-O-R.
Ditor.
Yeah, so Ditor is a fluid medication like Lasix. Ditor should not help with your cough unless you have fluid in your lungs. And we already mentioned fluid in the lungs should not happen if you truly have just pure pulmonary hypertension.
Pulmonary hypertension. Okay. There was a question on how to deal with leg cramps which occur due to high dose of Ditor.
Supplementation with magnesium and potassium. So check your electrolytes, and if the potassium levels are low, make sure that you're supplementing that, and taking magnesium pills. That can help. Okay.
Okay. There's a question on menstrual health, and our doctor has recommended this female patient hormonal meds. Is it safe for in the case of idiopathic PH?
But hormonal meds, so let me put it this way: there is no absolute contraindication, meaning there is no reason not to use it. If used for the right reason, you can use it. Very, very rare instances, certain combined hormonal contraceptive pills which have estrogen and progesterone can increase the risk of having blood clots. So if you have a tendency to form blood clots, or if you have a hole in the heart, prefer avoiding to use these combination hormonal medications.
Okay. There's a question on can diet changes help with the acid reflux issues caused by medications?
Yes, absolutely, it can. So having lesser masala and not going to sleep immediately after eating, just remaining in an erect posture at least for an hour after you eat, those will help reduce the acid reflux.
Okay. There's a question on how important is NT-proBNP in heart failure?
So NT-proBNP is again one of those important blood reports that we measure serially that tells us about the disease severity. NT-proBNP is one number that comes in most of the 99% of the pulmonary hypertension risk stratification scores. There are several risk stratification scores which help to prognosticate or tell us, what is your risk of having worsening pH. So all of the scores, be it, the European Society, the Australian Society, the American Society, everyone and each group of investigators, they have NT-proBNP. So NT-proBNP is one of the strongest things that have been correlated with prognosis in pulmonary hypertension. Higher numbers are worse, lower numbers are good.
Okay, this is a question from a patient with thalassemia. She has two questions. Can pulmonary hypertension medicines cause DVT, deep vein thrombosis? And her other question is, do we need to increase the blood transfusion frequency in pulmonary hypertension?
So answer to number one, I don't know of any existing medications for pulmonary hypertension that increase risk for DVT. Answer to question number two, we in thalassemia generally we take help of a hematologist to help us manage the thalassemia part, and we manage the pulmonary hypertension. The goal of doing the blood transfusions is basically to maintain a minimum level of hemoglobin. In pulmonary hypertension cases with right ventricular failure, we may want to keep a slightly higher hemoglobin level. So yes, there may be a slight increase in the amount of blood transfusion that's required. But again, it all depends, on the patient. It's not, a general blanket principle that if you have PH with RV failure, you are going to need more blood transfusion, but it depends on a case-to-case basis. It's a decision which is made between the hematologist and the pulmonologist or whoever the cardiologist is taking care of the PH.
Okay, and related to this again is, are there any pulmonary hypertension meds that need to be avoided due to hemolysis?
Due to what?
Due to hemolysis?
No.
Nothing.
You need to check. You need to check your G6PD levels. I'm sure if you're talking about hemolysis, your hematologist would have checked that. And even then, I don't think any medications need to be avoided.
Okay. And how often do you get an NT-proBNP test done, doctor?
So I generally do it every time my patients follow up for an echocardiogram. So, like I mentioned in the first half of the talk, initially every 3 months at least. And then if they're doing better, maybe every 6 months. And then if they're stable on a particular regimen of medications, then maybe once a year.
Okay. There's a question from a patient with scleroderma and ILD. Can a surgery with local anesthesia be done for a pH of 80 or above?
Depends on what you're operating on, but local anesthesia generally should be well tolerated. But again, these are extremely challenging patients, especially if you have ILD, so your lungs are already compromised, and plus pH, the heart is also struggling. So you should not take my advice right now as a general advice. You should speak to your physician and cardiologist and ask them about it. Okay.
There's a couple of last questions. Are varicose veins common in DVT and PE patients?
Yes. So let me see, how can I frame this properly? Not all patients with DVT and PE have varicose veins, but a lot of patients with varicose veins do have DVTs. So having varicose veins increases your risk of having deep venous thrombosis. Okay. DVT, and as a result, that can travel elsewhere and give you a blood clot.
Correct. Okay. I'm sorry, I'm asking this question only now. It came out 12:30. There's a question. Is there any relation between right heart failure and hypoxia? And a related question: if saturation goes down, is this an indication that right heart is progressively failing?
No, so there is no direct relationship between hypoxia and right heart failure. Basically, I'll tell you what could happen is generally our pulmonary hypertension patients, the group 1 pulmonary hypertension patients, meaning not the ones with the ILD, not the ones with the lung problems, generally their oxygenation should be okay unless you have a hole in the heart. Okay. In very, very, very advanced cases, we see that the oxygen requirement, they start having a small oxygen requirement, which increases. So, and we know that low oxygen levels, if uncorrected, can worsen the pressures. It can reflexively worsen the pressures in the lungs. So if you have low oxygen levels, we generally want to keep the oxygen levels at rest at least above 92%. If you have low oxygen levels, give oxygen. If so, low oxygen levels, increasing pressures as a response to that, increasing pressures causing increased strain on the heart and causing right ventricular failure. That's how it can be related. There is no direct relationship between low oxygen levels and RV failure, but it can be sort of this leading to this leading to that.
Okay. Doctor, one last question. It's coming from a PVOD patient. She's asking, how is cough managed in a patient with PVOD if they are tolerating the ambrisentan and sildenafil?
Tough. PVOD is extremely rare. And if you are fortunately tolerating the ambrisentan and tadalafil you mentioned, then
sildenafil. This patient is on
ambrisentan and sildenafil. Okay. Maybe switching over to from ambrisentan to an alternative agent, maybe a macitentan, you could try that. If that doesn't help, then talking to your treating doctor about maybe using a short course of inhaled medications to help with the cough. I know it can be very annoying. PVOD, you also have to be worried about fluid filling up in the lungs. So if all of those things do
What is the indication for that, doctor? Fluid filling up in the lungs for anyone, not just in PVOD. How do we know? Is there any
cough which is typically worsening when you lay down is a general indicator, but in PVOD you can just have this dry cough which is there the whole time. It doesn't really matter about position, morning, night, whatever. It can just happen. And generally in PVOD, as you tend to add medications, that cough worsens.
Okay, so does withdrawal of medicines help in this case?
Correct, but then it's withdrawal, and what are we left with then in PVOD? So we have to sort of weigh the risks and benefits. If it's too debilitating, then yes, but then you're talking about no therapy at all for someone with PVOD and severe pulmonary hypertension. Then the only thing left is talking about transplant.
And this patient is saying that I have wheezing which worsens when I skip lacilactone for even a single day.
Not typical.
Not typical.
That is not typical of pulmonary hypertension. Again, you should talk to your cardiologist, pulmonologist about that.
Okay, I think, doctor, we should close this now. You must be tired and you must be hungry. I hope all your questions have been answered. Everyone who's joined here today. Let's close this session now. Thank you, Dr. Talha, for taking your time.
Most welcome.
Very informative session. You answered all our questions very patiently and kindly. Thank you for showing us a unified approach in asking queries to our doctors and also highlighting the importance of knowing our symptoms and when to act on them. I would also like to thank my team members at PHI who constantly wish to improve and make the best of their lives, especially our social media team who made this event visible around us. In the end, I would also like to thank all the viewers who attended this session and for promoting PH awareness with us this month. Thank you, everyone, and you have a great evening. Thank you, Doctor.
All right. Thanks all. Take care, everyone. Thank you, PHI. Bye.